OPR contacted me via a DM on Instagram. She said, "Hey, Raf, I'm loving your AMAs. I can tell that so much critical thinking and reading goes behind it." Well, thank you. "I've always heard my flexibility teachers and physios talk or warn me about muscle compensation and that I have to engage or use the correct muscles so over time I don't end up with a muscle compensation related injury. Since starting at Breathe, I've heard Heath and the teachers talk about the body just knowing what muscles to use. So I'm kind of conflicted on what to believe, if muscle compo is a thing, to what extent, or if it's a load of bull. Can you shed some clarity on this topic for me? Thank you." Well, I will do my best. So muscle compensation is a thing, but it's not a thing in the way that most people think it's a thing. So compensation, just means when a body structure is unable to fully do its normal job, some other body structure can sort of take over part or all of that function. And a great example is if you injure your anterior cruciate ligament in the knee. So if you picture the knee from the side view, there's a femur bone, and I'm going to draw a super simplified version here. There's a femur bone which looks like a big kind of marrow bone. Then you've got a tibia, which is the shin bone. And then in between the tibia and the femur, running from the back of the femur to the front of the tibia, is a ligament inside the knee called the anterior cruciate ligament, or the ACL. And that ligament, the ACL, one of its primary roles is to prevent the tibia sliding forwards on the femur, or the shearing forwards would be another way of calling that. And they actually call that, let's just call it anterior shear of the tibia. And the ACL prevents that. Now, there are multiple other structures that also run in exactly the same direction as the ACL. So, for instance, you have on the outside of the knee, you have your iliotibial band, which is a tight band of fascia that runs down the outside of the thigh and inserts into the tibia and runs almost exactly parallel to the anterior cruciate ligament. And behind the thigh, you have the hamstring muscles, one of which is called semitendinosus. Semitendinosus, that's one of the inner hamstrings, and its tendon runs on the inside of the leg, almost exactly parallel with the anterior cruciate ligament and the tendon of the IT band, the insertion of the insertion of the IT band. So if your anterior cruciate ligament is injured, if there's some kind of problem with your anterior cruciate ligament, well, if it's been shown experimentally that if people just, contract their hamstrings more and also contract their tensor fasciae lata more and gluteus maximus more, well, that can essentially fully compensate for the lack of structural integrity in the anterior cruciate ligament. So the tibia remains just as perfectly positioned as if the ACL was fully intact. So that's an example of muscle compensation. The muscle compensation is a real thing, and it has been documented to happen, and it's a good thing. It's redundant. We have redundant backup systems in our body. So if there's a problem with some part, other parts can take over some or all of the function of that part. That's a good thing. And that's why we see people who have a limb amputation or a severe scoliosis or, other, significant physical asymmetries, that they're often able to function, at a very high level. And we see like Usain Bolt with a scoliosis and a leg length difference the fastest human who's ever lived, who's ever walked the planet. We see someone like Lamar Gant, who was the first human to ever deadlift 5 times his own body weight. Yes, I said that correctly, 5 times his own body weight. And the man had quite a severe scoliosis, so much so that if he hadn't have had one, he probably would have been 2 or 3 inches taller. And there is a very, very long list of people with significant asymmetries who have been able to perform at an extremely high level in many different sports because of compensation. So because, certain muscles or ligaments or bony structures were weaker on one side or misshapen or asymmetrical or whatever, the other side or some other group of muscles, ligaments or tendons or whatever, compensated and they were able to perform. So compensation is a real thing. It's generally viewed as a good thing. When you've got a problem, you compensate for it and you can still keep going. Now, the second and probably less useful way of thinking about compensation is thinking of compensation the way that I guess most Pilates instructors would think about it, that it's a bad thing, that we're not supposed to compensate. But it's also very, I think, very muzzily defined. So the idea of, behind the second definition of compensation is that it's some kind of dysfunction, which I'm putting inverted commas around, and that there, which presupposes that there is some ideal, quote, functional state that is optimal. In which all of our muscles are equally strong and equally flexible and fire at the correct times, and our alignment is, balanced and even and centered in the joint, and everything is working in, synchrony and harmony. And that to the degree that we deviate from this sort of ideal mechanical configuration, that then we cause addition, so if one muscle's pulling harder than the other muscle, or if the joint is a little bit out of alignment, or, whatever it might be, one muscle's tighter than the other muscle, etc., that we then are pulled or pushed or whatever out of our, quote, ideal sort of mechanical configuration, and then we create compensations because one muscle has to work harder and the other muscle's not pulling its weight, and then we somehow that causes an injury or wear and tear, and that has just generally not held up to evidence, that idea. So there's one particular study that I'm thinking of. So we could look at multiple lines of evidence for this. So, for example, there's a there's a lot of what's called epidemiological research on this. So, for instance, looking at the relationship between sitting posture and neck pain, or shoulder posture and neck pain, or ergonomics and neck pain, all show that there's basically no relationship. The literature looking at the relationship between foot posture, pronation or supination, and running injuries, and what we find is there's basically no relationship. The literature looking at muscle firing patterns in the abdominals and spinal muscles, so the transversus abdominis, the multifidus muscle, the deep muscles of the spine and abdomen, the relationship between the timing of those muscles and whether someone has low back pain or not. And we find again and again there's basically no relationship between those things. So there's lots of sort of observational evidence, but actually, like the even higher quality evidence comes from randomized controlled trials, and there have been a few. And there's this one in particular which was done in 2017 by Azevedo et al. And it was called Movement System Impairment-Based Classification Treatment versus General Exercises for Chronic Low Back Pain, randomized controlled trial. And so what they did basically was they had 148 participants with chronic low back pain, and they were randomly assigned either into a general exercise group or a movement system impairment-based specific exercise group. And both groups had 12 physical therapy sessions, so that's in Australia what we call physiotherapy sessions over an 8-week period. So they had 2 sessions a week for the first 4 weeks and 1 session a week for the second 4 weeks. Each treatment session was between 45 and 60 minutes and was supervised by trained physiotherapists. And so basically the intervention group, the movement system impairment exercise group, they got evaluated on a whole bunch of parameters. So here are some of the tests that they did. They did standing posture assessment, looked for asymmetry and regularity of the lumbar spine. They looked for posture type and shape of the lumbar curve. They did posterior pelvic tilts against the wall. They did forward bending to measure lumbar flexion, lumbar extension, and relative flexibility of different parts of the spine. They corrected the forward bending and noted whether that had any effect on symptoms. They did the return from forward bending. They looked at the timing and the relative contribution of their hip extension, their lumbar extension, their pelvic and shoulder movement. Then they corrected that and saw and measured whether that had any effect on symptoms. They did sitting, looked at different sitting postures. They looked at knee extension in sitting and looking at whether that caused the lumbar spine or the pelvis to rotate. They did supine, lying on their back with knees flexed, knees extended. They did lying on the back with knees bent with hip abduction and looked at their hip flexibility. They corrected their hip abduction. They lay them prone, looked at their relative flexibility between their knees and their hips. They corrected that. They looked for asymmetrical pelvic rotation. They looked for hip rotation, relative flexibility between hips and asymmetrical pelvic rotation. They looked at hip extension. They looked at quadruped, so on all fours. They looked at the lumbar alignment, any asymmetry or any alignment of the hip joints. They corrected that and then measured for symptom change. They lifted the arms and looked at the spine when the arms were lifted, when each arm was lifted, whether there was asymmetrical lumbar spine movement. They rocked back and forwards on all fours and looked at their relative flexibility between the hips, the shoulders and the spine and the pelvic rotation or tilt. Then they corrected that and measured symptoms. So it was a very comprehensive assessment. And for each of the items, I'm reading here now from the study, the participants assumed a position or performs a movement and reports the status of their low back pain symptoms. So symptoms either increased, decreased or stayed the same. Positions or movements associated with increased symptoms are followed by corrected alignment or movement involving minimising the lumbar movement, that's the low back movement, that occurs in the early part of the range of motion, or that is excessive, in the opinion of the physiotherapist, while increasing movement in other joints, i.e. the hip joint. An improvement in the symptoms indicates that the movement or alignment impairment in a specific direction, i.e. extension, is associated with the patient's symptoms and helps to decide on the participant's movement system impairment classification. For each of the items, the examiner judges the alignment of the lumbar region in different positions and or looks for incorrect timing and or magnitude of lumbar movement during trunk and limb movements. Alignment of lumbar region in a specific direction in different positions and incorrect timing and or magnitude of lumbar movement help to decide on the participant's movement system impairment classification. And relative flexibility refers to motion of adjoining segments occurring more readily in one of the joints. So, for example, if the lumbar spine moves more easily than the hip joint, even if the motion should be occurring in the other joint. In general, if patient exhibits a relative flexibility impairment, if the lumbar region moves in the first 50% of the ranges of the overall movement or excessively during the overall movement. So that is, it's a very in-depth classification and physical assessment. And then the treatment group got basically exercises targeting those impairments that were identified. So they got exercises to correct their flexibility imbalances, their movement control imbalances, their asymmetries, etc. And the other group, the general exercise group, got symptom-guided stretching and strengthening exercise. So they got everyone in the group got the same program. It was basically just spinal exercises, spinal flexion, spinal extension, spinal side bending, and spinal rotation. They got hip flexion, hip extension, hip rotation, hip abductors, and hip adductors. So they just did static stretches for each of those for 30 seconds. And if that made their symptoms worse, they discontinued that particular stretch and then tried it again later. So basically, that's what they did. So one group basically just got the same, and then they just got some basic strengthening exercises for abdominals and the back muscles. So they basically did 3 sets of 10 reps of, abdominal curls and stuff like that. And so at the end of the trial, what they found was, and I'm just going to read from the conclusions here in the abstract, results. There were no significant between-group differences for the primary outcomes of pain intensity at 2 months and disability at 2 months. There were also no statistically significant differences between treatment groups for any of the secondary outcome measures. Conclusions: people with chronic low back pain had similar improvements in pain, disability, and global impression of recovery, with treatment consisting of symptom-guided stretching and strengthening exercises and treatment based on the movement system impairment model. So that is an example, and there are many others, of a study that has looked at, the idea of imbalances or compensations and done an intervention, Freudian slip, I said invention, an intervention to, quote, correct those imbalances and compensations, and found that it works no better or worse than just doing some general strengthening and stretching exercises. And that finding is extremely robust in the literature. It's been very well replicated. And I'd say it's pretty uncontroversial amongst researchers, and is enshrined in just about every clinical guideline around the world, that general exercise is just as effective. So in other words, just a general strengthening and stretching program is just as effective as specific exercise that targets, improving some parameter of movement, whether it's muscle activation or posture or alignment or whatever it might be. So basically, are compensations a thing? Yes, they are, but not the way that people generally think about them in the Pilates and possibly the physio world. And generally, compensations are actually a good thing if you have a body part that's not working properly because it's damaged or injured or grew up weak or is asymmetrical or whatever. Well, congratulations, not a problem. We've got multiple backups, so your other body parts can take over. Yay for you, that's awesome. And secondly, we have this kind of not quite clear definition and not factual definition of compensations mostly in the Pilates world, I think, where we see it's a deviation from some kind of idealized optimal biomechanical, scenario, and that any deviation from that is a bad thing because we're using too many of one muscle and not enough of another muscle. And what we find is that is just not the case. So hope that answers your question and puts that to bed for you.